So for our luminary panel on brain technology, we have Kim Butts-Pauley from Stanford, Charles Kane from University of Michigan, Kalervo Hinnanen from Sunnybrook and the University of Toronto, and Dennis Parker from the University of Utah, Eyal Zedekaria from Insightec, Jean-François Aubry from Institut Langevin, and last and certainly least, myself from the Focused Ultrasound Foundation. All right, so I think we'll begin our panel session on brain fuss technology issues. And I think you have before you pretty much the experts on imaging issues, transducer and related issues, patient-specific issues, and different bioeffects. So I think we got a lot of that represented. So I guess I'll lead off with the opening question of, on the panel, what do you think the most important technology issue is that remains today? Now, a lot has been said about treatment envelope, but I think in the past we would have said that. Is that still the most important issue to solve? Jean-François.
I was about to say that we should better ask for visionary award. Kalervo, what do you think? What is your vision?
Yeah. Well, of course, it's one of those issues we need to solve, but there are many other issues. But that's maybe the first one, to extend it throughout the brain.
And so, it's almost the same. I guess we all agree that expanding the treatment envelope is very important. But the question is how? How should we do that? And do you think, should we? Do we have some echo? So there are several ways to do it. Improve energy delivery for thermal, or switch to non-thermal. What I have to ask the other members of the panel what, according to them, is the best way to do, or how they would do it. How to improve thermal.
Well, actually, we've addressed that problem with a poster that's here, and John Sukovich is the one that did the work, and he's sitting back there. I'm sure he'd be glad to talk to anyone about the issue, but as a summary, what we were able to show is that with histotripsy, we were able to make volumetric lesions at almost any place in the brain within a centimeter of the brain. And sometimes much closer, 5 millimeters or 7 millimeters, depending on the location. And that's all in that poster. And I should say this is not just a single focus. It's a volume that's always larger than about a centimeter in diameter. Not only that, this was done without aberration correction. If we do aberration correction, we can get much closer to the surface, 5 millimeters or so. And so if you're going to do histotripsy, this may not actually be a problem. I think it's definitely a problem for thermal therapy. And the reason that's so is because for hemispherical array, the sweet spot is right in the center of the brain. And if you move the array around and the angles become too acute, you lose aperture. If you lose aperture, then if you lose enough aperture, you're behind the 8 ball as far as physics is concerned, and there's absolutely nothing you can do to solve the problem. Aperture goes down, the cone of entry gets smaller, so the same amount of energy has to go through that intervening tissue, and it heats up quickly. So I think for thermal therapy, the problem is how to maintain aperture when you're tilting this large array around to get it to conform to the position that you're trying to do a lesion. I think John has sort of addressed some of that in his talk.
So y'all, from the Exablate neuro perspective, what's the way forward in the short term, at least with treatment envelope issues?
Yeah, I think two things. I think first of all, you asked what would be maybe the major or the top goal, and is it still treatment envelope? I would say in a wider scope that treatment even in the spots that we're treating today. And one of the things that we need to work on, and it relates to treatment envelope, and do that in a second, is treatment repeatability, robustness, and predictability. I mean, the fact that you can always in each patient get to the temperature you want, at the target you want, and at the shape you want, is something that we are now learning and confronting as we're getting more and more data. Is that, and basically I think it all goes back to the interaction between tissue and acoustics. And there are things that we simulate and they work well on ex vivo skulls, and they even work well on a certain group of patients. But as that population expands and we get more and more data, we learn that there are things that we need to know in greater detail. And I think that goes also to treatment envelope. And later talk about SDR and how that affects that. But I think treatment envelope in the general term, on the thermal ablation part, I think between thermal ablation and other treatment modalities, there's going to be pros and cons to each eventually, and we'll probably need to develop both. And we're pursuing in short term the thermal ablation mode, just in the sense that is the maybe more developed treatment modality, but we're also looking into ways to enhance that with other microbubbles or other techniques that will make it expandable to areas where direct or straightforward thermal ablation would not work.
I think eventually it might be a combination of bubbles and thermal, at least some applications, but the lesioning is very small section of what ultrasound can do in a brain treatment. So eventually there will be many other things. So.
You mean injected microbubbles?
Injected or generate
ultrasound induced?
Yeah, both. Either all the way to hysterotripsy or enhancing the thermal effects.
Yeah, I'd like to say sometimes you might want to treat a large volume. For example, if you have a blood clot.
Yeah.
And the larger the volume you can contemplate treating with thermal therapy, the longer you're going to have to wait until things cool down. You know that.
Yeah.
And I think at some volume, the physics just says it's not going to work. And I would like perhaps to have someone define that volume so that we know what can be done and not what we hope we can do. And I don't think that's a difficult problem.
Yeah. And I think part of the simulation teams are working on that to really estimate and show what we can do in terms of treatment time and treatment envelope.
I mean, the physics is what it is. And no amount of wishful thinking will make it different. So, and I think the physics can tell us some of these answers.
Kim?
Yeah, I just wanted to add that we know that the efficiency of the transmission of ultrasound across the skull is very variable, at least a fourfold variability in the essential tremor patients that we've looked at, and if you look at the population as a whole, it's even more variable than that. But my point is that treatment envelope may be patient specific, and it's not clear that if you take somebody who's very efficient, how that efficiency gives you more flexibility to have a larger treatment envelope.
Well, another issue I was talking to John about before this panel is that I think there's some work that could be done to optimize the transducer itself. For example, if we want to form a lesion close to the interior surface of the skull at a certain location, if we sort of did an inverse problem to find out what would be the optimum aperture to do that, and then do that for different places in the skull, we might come up with a finite number of different transducer shapes which we could choose for any given application. I mean, having this huge hemispherical array and expecting it to work for each of these different situations is perhaps too much to expect. Particularly if you're running up against the physics of treating a large volume thermally through the skull.
Kalervo, in addition to the actual geometry of whatever the transducer array is element count a factor?
Of course, and I agree that the optimization of the array is great, and I think it will be personalized arrays for all the patients, but if you want to treat more complicated tumors or targets. But the element count, of course, matters, especially with thermal. I don't know how much it matters with histotrypsy, because there you just need to get a high enough intensity for very short time, so the skull heating is not an issue. So for thermal, you want to cover the whole skull area, so you need lots of elements if you want to do any electronic steering. For blood-brain barrier opening, you don't need as many elements because you don't need much power going through the skull. So there you can do electronic steering with fewer elements.
So when we talk about treatment envelope, I think we usually mean sort of spatial terms. You know, what's the intracranial volume we can address with whatever bioeffect we're thinking of, and for thermal now anyway. But the other dimension that I think we need to start thinking about, particularly with volumetric targets, is the time dimension. How long? You know, not only can we reach far enough, but do we actually clinically have enough usable time to deliver the treatment for a given volume? And are there strategies? You know, today we're doing focal targets, so we're not worried so much about treating a volume. But when we think about tumors or epilepsy or some other things that might, BBB opening even, where we potentially have very large volumes but still kind of limited clinical workflow time, what are the answers to coping with that?
But I think, John, as we define that, we need to also add the constraints to what do we mean when we say treat, because I think you compare, I think Kim touched upon it in her talk, that we spend, or a lot of time is spent today on the alignment and the calibration phase of making sure not only that you're at the right target, but you don't have any side effects around that target, because we're treating targets where a fraction of a millimeter makes a difference. Now, if we change that paradigm to a tumor or to other targets where that level of accuracy is not needed, then that would impact treatment time significantly. Essentially, what we're doing today is a one sonication treatment. So you could say it's a 20-second treatment. Okay, but it takes you maybe 3 hours to get to those 20 seconds where the parameters are all set, because we don't yet have the tools and the detailed understanding of acoustic and tissue interaction to, for example, immediately and instantaneously deliver the right power and the right parameters. We gradually increase things and we gradually align everything, and that adds up to a very long treatment. But it's both due to the understanding we need to develop and what do we define as the clinical requirement. The one case blood-brain barrier opening was not that long as we expected, because we did not need that sub-millimeter accuracy. So I think before we define treatment envelope, we need to really define what treatment means and how we are concerned with the surroundings and with secondary hotspots and with all kinds of things that may develop once you apply more advanced techniques.
Just because it's come up several times, I think, during the day, it might be helpful to, let's talk about SDR for a second. So can somebody define for the audience what is SDR other than this magic acronym? What do we mean by it, and why does it pose a challenge, and do we understand what the underlying phenomena is?
I'll give it a try. So let's say you draw a line from your target to the transducer, and it goes across the skull, and you say, well, what's the maximum Hounsfield units? And then it goes through the trabecular bone, and you say, what's the Hounsfield units there, and then in the trabecular bone, and that's the minimum. And then you take the ratio. So it's the ratio of the minimum Hounsfield units in the trabecular bone over the maximum in the cortical bone, and that's the skull density ratio. So if that ratio is a high number, or close to 1, that means there's not a lot of trabecular bone, and we know the trabecular bone is very, very lossy due to scattering. If the number, so like 0.6 is something that's relatively easy to treat. If the number is kind of low on the 0.4 side, then that means there's trabecular bone, and it is very porous, and so the Hounsfield units go down, and so that means that it's going to be a lot of losses due to scattering.
And we think scattering is the major loss agent in that issue.
Yeah, so if you say, well, what are all the contributions to the loss? I mean, there's how much bone there is, so skull size, skull thickness, but also how much trabecular bone. is like the next, maybe. I don't know if you guys have other opinions, but that would be my opinion. Yeah.
And that's where we found the correlation, and that came in retrospect. And I think, again, what Kim mentioned is exactly how we calculate that, but that also varies across the skull. With the personal, I mean, with each single skull, different areas in the skull have different local skull density ratios, and then it's a matter of per area how you average that. But we tried to come up with some kind of a number that scores how difficult or easy a treatment will be, and that. It's not a perfect correlation, by the way, but it's the closest one to kind of predict if this is going to be a long or a short treatment, or will require more or less energy.
So currently that's a mean over all the elements.
Average
basically.
over the area, yeah. That's the way we calculate it now.
We have had experience where we have been able to treat very easily with low numbers sometimes.
Exactly. So I would say, so it's a way to kind of predict how the system would work. But it does not mean that it predicts how much energy is going through the skull. Because it could be also that there's some room for improvement maybe in the simulation, in estimating the phase shift and compensating for it. So to answer Jin-Woo Chang wish list this morning, when he is asking to treat more patients, and maybe one way could be to work on the simulation and see for those patients for which it's difficult the treatment is difficult to achieve, there might be some room for maybe simulation that might take a little bit longer, but some refinements to be able to increase the temperature. It's in terms of transmission, the energy deposition is proportional to the square of the pressure. So each time you improve a little bit the simulation, even by 10%, then it's a huge increase in temperature. And I would say that for those patients for which the temperature is not high enough, just a couple of degrees more might be enough. So this is something we should, I guess, at least look carefully at and see. It might be a very small change in terms of workflow, but if many more patients can be treated, it might make a big difference. Obviously, especially in Asia.
Yeah, I'd like to address the treatment time issue by sort of a different way of looking at it. There is such a thing as a thermal dose, and that can be optimized. And if you just form a lesion in a single focus and then form one right next to it, then in order for there to be an overlap, then you probably are way over the dose in the center of that focus, and just so that the edge will reach the threshold. And then, of course, if you're doing something in time, then the whole temperature of the volume starts rising. And so you can, and we looked at this something like 20 years ago, you can actually compute an optimum trajectory for doing this where the total amount of energy that you impart into that volume is minimized, yet every part of the volume it reaches a thermal dose. In other words, what you want to avoid is a situation where you're overkilling some part of the volume. And that's exactly what happens if you use individual foci and you scan them. And if you actually do that computation, you'll find that you've actually propagated way too much energy through intervening tissue, which is the problem. So you need to minimize the amount of energy that you propagate through intervening tissue by optimizing the thermal dose and the volume. So that's a doable problem.
So maybe related, I'll throw out the question. For some of those kind of on the hairy edge of the treatment envelope locations now, is a slightly lower temperature, slightly longer exposure, thinking of it in terms of the delivery of equivalent minutes. Is that a viable thing, or is bone safety, and it is an issue, but is it something that would prevent that from being clinically valuable? Anyone?
No, that's right.
Go ahead.
Nobody knows. I don't know either. But
Well, I mean, why not? I mean, you can increase the time and we do it routinely. So.
I mean, obviously you're not going to treat a large volume that way, but for some of the focal functional targets that are a little difficult to reach 58, you know, if the histology bears out from work like Dr. Pang showed, you know, is it possible we might equivalently deliver a lesion, just it'll take a little longer, but we don't have to get to 58, we might have to only get to 48.
Yeah, I think that's valuable data to have, and I think both Nathan showed work, I think Lever's shown work where we can get effect in the brain that's lower than the 240 equivalent minutes. And I think if there's a different scheme, like Charles said, to deliver those equivalent minutes, then that's and it can be applied in treatment. I think it's a workaround that we are starting to use already now, and definitely a viable solution for now.
All right, let's switch topics a little bit now. Image guidance. So obviously, for the time being, MR guidance is going to rule the world in terms of brain. But do you see a future where, at least for some indications, that having to do this all actually in the bore of a magnet might be optional?
No, I'd like to address that because one of our primary goals is to get the patient out of the magnet when the surgery is performed. And I think the reason the patient's in the magnet now is because there was no good feedback way with ultrasound imaging, and more to the point, no way to measure temperature. So the patient's in the magnet because we need some thermometry. Well, non-thermal approaches, we don't need thermometry. Histotripsy, we don't need thermometry. But we still need to localize the bubble cloud, which actually produces the lesion. But we found a way to do that because we have our pulses that we use are sometimes even shorter than imaging pulses, and they're very highly intense pulses. So when they actually generate a bubble cloud, there's a significant amount of backscatter. And that backscatter is sufficient that if we have each element of our transducer actually also be a receiver, then we can actually form a three-dimensional image of the bubble cloud in real time with that system. And so our idea is somewhat similar to what John was talking about, where we would have preoperative MRI data sets, high-quality data sets, because we have plenty of time to do them. And then we would use image registration techniques to overlay this image of our bubble cloud onto those data sets. And we could also include CT. So that's kind of where we see histotripsy going for brain treatment. In other words, our goal is to get the patient out of the magnet.
So how about some of the other panelists? You have comments about the requirement of MR?
So for peria opening, that's the same thing is true. And I saw this morning image is measured in vivo with our array where we can receive and form the bubble cloud and the spectral information in 3D during the ultrasound pulses to control the exposure. So, and then we have to even plans to go further, not having the frame, but do localization online. And we just had a paper coming out showing that we can localize the skull with very high precision and use the prior CT and MR information to localize the target. So I think that's clearly where it's going to go eventually.
And of course, you can use stereotaxic procedures with that.
Yeah, so you can if you need to.
John, I think you have to ask the clinician that question and ask them, you know, are they comfortable just looking after the fact and not looking kind of along the way?
Well, you might ask the radiation oncologist about that.
Right, but I think that's where the difference is. I think as long as we believe that there's a role for real-time feedback and decision-taking, intraoperative decision-making, then it goes back to where within radiation where that does not exist, then it goes back to what type of feedback satisfies the clinicians to take those decisions. And again, we know now that variability with acoustics matter a lot in the skulls and in tissue. And so it's not going to be a therapy where you can go without monitoring and real-time feedback, whatever that is, ultrasound or other imaging. With thermometry, it's I think more straightforward. It'll stay MR. If it's going to be any other form of feedback, it will have to establish the same level of evidence where imaging that bubble cloud really matches histology in real time, in retrospect. And what type of feedback do you get, by the way, like what Kim mentioned now, gradually as you align your target, and do you get some partial feedback before you get the definitive treatment to make sure you're on the target before you actually destroy it. So I think feedback is a critical part and will always stay a critical part. Will a different imaging modality replace MR? Maybe, but it goes back to the clinicians to what type of feedback would satisfy them to take decisions and to make sure that they're on target before they're actually ablating it or destroying it in other means.
Well, I think it's pretty clear.
There's a
that-
clinician there that wants to ask something.
Yeah, Dennis, go ahead.
No, I was just pointing out there.
Yeah,
Well,
the one of the clinicians
we'll
came.
tell them what they're going to use.
Okay.
I think it's pretty clear that ultrasound is never going to give us the contrast or the resolution to actually see the anatomy, see the tumor. So we're always going to need MRI or some other high-resolution image. Now, whether or not that's in real time when you're doing the patient or it's a preoperative data set, well, we'll have to see what the physicians are willing to accept.
So seriously, if there's a clinician in the house that has an opinion, please approach the mic. And are there
Thank you, Jeff.
are there situations where you would be happy to dispense with MR?
No, I think that I think we should embrace the MR and not get away from it. I mean, I think just seeing an anatomic image is, I agree with you, that's not that useful. But the future, I think, of MR will be looking at connectivity and watching brain function actually as we're doing a treatment. I think that'll guide our treatments more than just anatomic imaging. So, I mean, I think the ability to bring in FMR, DTI, other types of imaging, perfusion, will help us refine these treatments even more than just taking a look to see what we ablated.
Yeah, and I think,
I've been very quiet, John.
Yeah, no, go ahead.
I've been a good boy. No, I think that what we're seeing though is that MR right now, with the current systems, it's very limited in signal-to-noise ratio and in the ability to see what you really want to see. I mean, those are great ideas, but for MR to do tractography or things like that while you're treating would be very difficult until we improve the collection of the signals from better antennas and.
I was going to say, how do we do that?
Yeah, that's a good question. I know Stanford's doing some good work on that, and we've been working, but we need a system, of course, in Utah.
but I think asking that question, you can't assume that MR will stay what MR is today. Because I think MR, what we use today in therapy today is basically what diagnostic MR made available. This doesn't have to be in the future the same way. I think therapy demands will also have their input on MR, and MR in the future may not be the MR we use today. And then I think there's always going to be a gap, and will that gap be beneficial enough for clinicians? I don't know, it will depend on the application, but I think from advanced functional imaging to advanced RF techniques, there's a lot of multiple things you can envision MR moving forward. And if you're looking for a visionary statement looking forward, you can't assume MR will stay where it is today as well.
Well, I think that in the prototype system that we envision for histotripsy, it would be MRI compatible. Yeah. It would be possible to actually do the patient in the magnet or outside the magnet. So maybe some kinds of cancer treatments could be done more profitably one way than the other, or it could be left up to the clinician. And I think that once, in a lot of these things, once the clinician develops some degree of confidence in a technique, then they're willing to do things with it that they wouldn't do up until the point that they develop that confidence. And I think the ability to do both would be very useful on some of the preliminary systems.
So we've seen a number of talks on 3D thermometry. I think there seems to be general consensus that we more than want it, that we probably need it. how close are we to that being a clinical reality? And what, I know we're going to talk about this tonight, but we might as well give a preview. What remains really to be done to make that a clinical reality, given where we are with both the focused ultrasound equipment that's available, as well as head coils or other things we might do to kind of overcome SNR deficits that we feel.
So I'll bite first and then Seed. I think our experience is that technically you could do it right now with the 3D GRE stuff that Henrik showed was just product sequence on the GE scanner. So it's feasible to do that right now. I think the limitation is the FDA issues. For Insight Tech to adopt such a procedure in human scans would be difficult. And then the techniques from Stanford, from Vanderbilt. I mean, all of these, I think, are feasible. They may not necessarily be product sequences, and so it may take a little bit of work to do them. But there are product sequences that can at least improve, and you can see the full 3D distribution.
And again, maybe Kim or someone or Kalervo could just outline for the audience again, what the value of 3D thermometry over 2D is. Why do we need it? Go ahead, Kim.
I don't know. I feel like it's a self-evident truth there.
Well, I mean, I'm not sure that to you, yes.
So we have a focal spot which is bigger than our 3 millimeter scan plane. We are getting one slice, and we can move the slice around, but we can never image all of it. And especially we say in orthogonal scan planes, we can't image all of it. So if we could have a full 3D volume, then we could get the focal spot and see all of it. And if it's moving, then we could see that. But the other thing is there's the rest of the brain too. And so if in Parkinson's we're off center and there's more skull heating, then we need to monitor that. And so full volumetric thermometry would allow us to see the heating in the rest of the skull as well, not just at the target.
Dennis.
Well, I was just going to comment earlier that there's several studies that have been done, and Eyal, I think you mentioned also that there's a dose-damage relationship that's been, and there's these outliers that people have seen where lower temperature increases have also resulted in thermal damage. And it may very well be that we're just not exactly on the focal spot, and the thermal damage is not exactly registered to where you're seeing. I don't know. I wasn't there. but that's a possibility, and I really think it is self-evident.
Okay, so what about treatment monitoring? So for the most part, it seems that T2 enhancement is kind of what we look for to see whether we've created a lesion. But it takes a little while to wait for that to happen. Are there better, faster, or more accurate ways that we can tell whether we've created the lesion of the size that we want faster than we do now?
Yeah, I think the diffusion would show us the lesion faster, and like 20 minutes faster or something, and that's a significant amount of time, and so that's a significant challenge in terms of signal to noise and all the water, and how do you do diffusion in the transducer. But potentially there is something that would be better and faster than T2, but for now, yeah.
Dennis, do you have anything to add to that?
Well, I think we have some experience in Utah with T1, but not necessarily in brain, but other tissues. T1 can often show lesions very early.
And what about in bone? I mean, we're talking about in brain now, but can we measure bone heating?
Technically, yes. I mean, I should say physically, yes. It's technically not. It's not a solved problem yet. And I don't know, Kim, do you want to comment on? Okay.
Well, also,
I've gone too far on already.
Do we need to, or is measuring brain temperature proximal to bone enough?
There's strong evidence, at least in the skull studies that we've done with you, that there's a lot of delayed heating where the bone is bone has very quickly absorbed energy, gotten to very high temperature, and is offloading energy to the cortex or in the area of the bone. And you don't know what temperature the bone got to because we didn't measure it. So I think there's strong evidence that it's probably heating much more than you think it is, and that there's potential damage of the cortex. But again, if you move away from these thermal therapies, maybe that goes away. But anytime you're doing thermal therapy, there's a chance that there's heating in the bone that you're not seeing at all.
Yeah, at least for peripheral targets. Right?
Yeah, and I think, John, not just for damage. I mean, we in Kim's talk, I think there was a question. I think it's pretty much obvious that if the bone does heat up, even if it's not damaged, it impacts acoustic properties and other things that maybe we don't account for today. But if we knew that and we could account for that, we could have gotten those extra 10% that Jean-Francois referred to. So I think the more we measure, the more we learn, the more we can adapt into our treatment simulations and treatment planning, we will end up with better treatments. Now we're kind of compromising, so we can only do soft tissue thermometry and we can only do planar, not volumetric, but ideally if we could measure temperature in the bone, it will be very beneficial.
Clear.
So I think that the bone heating is the one that limits us, and I think it's probably spatial. So if you could map where the hotspots are, we could probably tailor the heating and get much higher temperature we can currently do. So if you solve the bone heating,
Next year.
Yeah, I think there's some evidence that creative editing of the array to remove contributions that are really normal to far field bone can actually help quite a lot.
I'd like to add a little bit about ultrasound feedback. We can see the bubble cloud, but that doesn't tell us anything about the damage. And one of the nice things about doing ultrasound or histotripsy in an MRI magnet is that we can very quickly see the effect. For example, basically what we're doing is homogenizing or liquefying the tissue, so diffusion imaging, it shows up very nicely. Also, T2 shows up nicely because we fractionate the red blood cells, and the hemoglobin is a nice contrast agent. So it is nice to have, to do these things in an MRI machine, but I don't think it's absolutely necessary. I mean, one of the features of histotripsy that's kind of nice is that it's self-limiting. So we can treat a volume for 10 minutes, which will liquefy in 1 minute, and the size of the lesion only increases very, very marginally. So if we know where our bubble cloud is, we can always have that extra safety margin. Now, one of the really frustrating things about thermal therapy, I think, is that it's very difficult to do that because there's a fine line between not having sufficient dose and having too much dose. And how you define that line sometimes I think is very difficult. If you have too much dose, then you harm the patient by intervening, heating intervening tissue, or having too large a lesion, or a lesion that that's ill-defined on your image. So as far as histotripsy is concerned, it would be not, we'd like to do it in an MRI machine, but we think it's possible to do it outside MRI machine. And certainly that'd be cheaper, faster, and
So is it,
what the clinicians decide is the best way, we can adapt to that.
so as a segue a little bit from that, what's the role of simulation? Oh, go ahead.
Well, yes, just
Talking
one
to your
point.
mic.
Just because we within almost 5 minutes we'll be done. And there was this morning, some of our friends, clinicians, gave a wish list. Maybe we should at least address some of the points. Some were not completely technical, but some were. And I think it would be good just to discuss them. Jeff Elias mentioned that he, if possible, he would like to get rid of shaving. So, a few years ago, we published a paper in the Journal of Therapeutic Ultrasound on focusing the ultrasound through the hair on cadavers with, on skull bones with wigs. and it seems to be feasible. And I guess Kullervo also did some. At least there's one publication, something like 10 years ago, also through EARTH, and through EARTH it could be feasible if it's not too dense. Don't lose much power, especially for the low frequency system, the 220. Definitely the loss is pretty small, and for the 650, if it's not too dense, then it should be possible.
Yeah, as long as you get the gas out of the hair.
Exactly. But at least, I mean, with the the air are in water, at least with wigs, and those were from real hair, it was working. There's some loss. So I would say I would maybe not be too much concerned about the efficacy of the treatment at focus as compared to the influence of the bone. Then it's more about safety for inducing skin burns maybe. But this is something we could maybe investigate a little bit more in detail if this is a real need from the clinicians.
Yeah, I think it's a need. We didn't, and again, I don't know how many of the clinicians are still in the room, but well, Jeff is not. But I think in terms of the technical things that we are addressing or that we have on our plate and we need to kind of prioritize, I think the key message that we are getting is that treatment, repeatability, predictability, and robustness is key, and that's what we need to focus on, so that every time in each patient you both know what you will get and you can get to the temperature every time. I think that's the key message that we're taking. Is that we're still not there in terms of really delivering that. I think imaging, there's a large list of requests from 3D thermography to intraoperative imaging and through DTI targeting, and there's more and more imaging, and I think that need will grow as we grow with the treatment applications that are being investigated. So I think imaging is kind of the second big thing that we need to work on. I think there's a lot of feedback that we're getting on all kinds of workflow and tools, imaging like you showed, John, your planning tool, but I think in terms of is a device that we're working on. There's a lot of tools that, because we're coming with a unique treatment workflow, it has to be adapted, and we need to advance that. And I think only, at least the way we see it, after that, there's a lot of patient comfort things that we need to address, both the frameless option and the shaving, and maybe some other techniques to shorten treatment time so it wouldn't be as long. But I think it does come up that the shaving is a big thing for patients, but I think when you list the things that we need to handle as a technical panel, then there's things that are still more critical than that, and we'll get to the shaving when the time comes.
Anything else on your list?
Well, in some point you addressed that. I mean, there were Vibor and Jeff also both asked for pre-treatment planning, and shaping, and so this is, I would say, on its way. Yeah. It's just that currently for precise pre-treatment planning and providing the expected temperature and size, those codes are quite time-consuming, but they can be optimized. Okay. And it's on its way. And you gave a good example of what can be done right now, just simply by taking into account the angle of incidence, and then those we would add more and more features on those. But apparently, yeah, it would be a nice feature for the surgeons. The last question from Jeff, it's not really technical. He was asking for neuromodulation before the treatment, so that's more bioeffect. So I would say neuromodulation is on its way, and it's also something that could be tested with the system. It's just lower power. So technically, this is possible to test. Again, this is more a question of setting up the clinical trials and getting the approval to test. It's not really technically, yes, it's feasible. It's possible to test it.
Well, I guess we're just about to the end of our time, so I want to thank our panelists for a lively discussion.